Hello and welcome to the CIS YouTube channel. I'd like to spend the next couple of minutes telling you about a new paper that the CIS is releasing this week. It's called How Not How Much, and it's about the relationship between the sacred cow of the health policy debate, which is bulk billing, and the long queues for hospital treatment that many Australians experience. What the paper shows is that in the late 1960s, Australian government spent $4.83 on hospital care for every dollar they spent subsidising non-hospital services. By comparison, in 2008-09, for every dollar the federal government spent on the medical benefits scheme, combined state and federal government spending on public hospitals was only $1.99. The cost of the MBS to the federal budget was over $15 billion. That's about double the cost of the private hospital system and half as much as combined state and federal government spending on hospitals. Now, the changes in spending reflect advances in clinical practice, such as tests that no longer need to be performed in hospitals. What the changes also reflect are changes in government policy, and they help explain why 26 years of Medicare has produced what is now known as the hospital crisis. Now, to cut a long story short, and the paper goes into this in a lot more detail, what has basically happened is that the federal government has offset the high cost of the MBS by restricting the amount of money given the states to fund hospital care. The predictable response by state governments, remembering that they have limited sources of revenue and large and competing service responsibilities, has been to clamp down on frontline hospital budgets in order to restrict access to care. Now, bulk billing is enormously popular with voters, naturally, because you can go and see the GP whenever you like for free, even if your health problem isn't that serious or even if it's non-existent. What isn't understood is that because of the billions spent on bulk billing, especially the billions that are spent on unnecessary consultations and tests, have actually led to longer waits for hospital treatment. Now, this is the reason that my paper describes Medicare as a reverse insurance scheme. What I argue is that the system is flawed in principle, because while minor health needs and costs are excessively subsidised, those patients with the most serious and most costly health needs are underinsured against the risk of needing hospital care. Now, the obvious thing to say about this is that the money spent on bulk billing would be better off being spent on treating hospital patients. But shoveling more money into highly bureaucratic public hospitals is not really the solution. What I also argue is that it would be mad to persist with a scheme that wastes money on unnecessary services and hospital bureaucracy when an ageing population is going to place heavy additional burdens on government budgets in coming decades. What the paper therefore calls for is a complete rethink of the way we finance healthcare in this country. And what I've done is try and outline some of the things that we need to do to create a more cost-effective system. The two really big ticket items that I canvass are, one, scrapping bulk billing and replacing it with a national system of health savings accounts, which would require people to spend their own money on GP visits. The second thing is to replace Medicare with a health insurance voucher scheme, which would only cover high-cost, chronic and catastrophic condition. Now, neither of these things will be easy to do when we're talking about tampering with an entitlement program as popular as bulk billing. But unless we get serious about cleaning up the health mess, the waste will continue, the cost of Medicare will become unsustainable, and the queues at public hospitals will be even longer. Thank you, and I hope you enjoy reading the paper, which is available at cis.org.au.